All right, guys. Very good evening. Can we all get started? Can we start? All right, guys. So, yeah. All right. So, without wasting any further time, let's roll. First of all the best for the INI-CET. I hope you get through whatever branches that you're looking for. I hope you do well for your exam as well. So, uh, I just have a couple of things, which I've jotted down for you based upon the trends from the last, 5 years, or you can say 10 sessions on a repeat basis. So before you go to the exam, I wanted to focus in these topics I've written in sequence. I've given you a cluster of 13 topics that you have to revise before you go to the exam. It won't take much time. Remember, max to max, it will take 2.5 to 3 hours to revise everything of this. So it's your last minute revision set that you need to go across, right? So trauma from the INI-CET part of the exam, it is extremely important. They're highly focused on trauma. They're talking about scenarios. They're talking about the patient presentation. They're talking about the management protocol. So very, very important sequence. Remember, we have to know about head injury, a lot of questions, fast, the favorite question, blood transfusions, shock, splenic injuries, bladder and urethral injuries. These are absolutely important from the trauma point of view. From the thyroid, they've been asking you about Graves, inflammatory disorders, carcinomas, and cytology, which I'll discuss in a bit. Breast, again, two important topics, always their favorite, that is abscess and cancer. Hernias, repair criteria and mesh status in liver, infections, benign disorders, and HCC. GIT, motility disorders, carcinoma of the colon, specifically bowel obstruction, Meckel's diverticulum, IBD, rectal prolapse. Absolutely important topics. Can't afford to miss out on that. In bile ducts, the newfound love is gallbladder carcinoma. Cholangiocarcinoma is there. Post-cholecystectomy pain. This I would like to give a star mark, right? This is what is going to look across the most important topic in the biliary system. Sphincter of Oddi dysfunction. For pancreas, you have chronic and acute pancreatitis and periampullary carcinoma. Transplant, again a favorite child. You have graft rejection, storage times, and ECD criteria for donor status. Nutrition, absolutely, total parental nutrition. Urology, RCCs, prostate cancer, VUR, bladder carcinoma, and genitourinary tuberculosis. All these are your set questions. Plastic surgery, without reading grafting, do not go. Wounds, three important topics: pressure sore, surgical site infection, and frostbite, right? These are absolutely top-notch important topics that you have to revise. So without wasting any further time, I'll take up the trauma, important questions. I'll tell you all those questions that have been asked previously. Now, in our previous INI-CET, I'll say the central exams, we'll use the word central exams. The first thing that asks you is, what is the triage based upon? What is the criteria for triage? Now, triage is basically a very simple component which you have to sort the patients out on the basis of the resources required for the treatment and the resources that are actually available. Let's say you have a patient with head injury, but you don't have a CT, you don't have a neurosurgeon who can intervene. There's no point keeping the patient. So the availability of the resources and the ability to treat the patient. These are the two criteria that you will look. It is not upon the severity, nothing. It's purely on that criteria, right? Now, we all know triage is basically the first forehead for any patient of trauma entering into a casualty or a trauma bay. We categorize the patient with a color code so that we can focus better. A band or a color code that I would never want to see on my patient is black, as it indicates dead or moribund patient. Red, it means emergency, leave everything and attend to this patient. Yellow, it is means urgent, and green, we call it as the orphan child of the casualty. Leave him across, go have a tea or a coffee, sip it back, come back and attend the patient. So here you can go with the delayed status. Here you can go ahead with the delayed status. Now, apart from this, the two important criteria for the trauma patient that you have to look across. Number one is the criteria for damage control surgery and the criteria for early total care. Now I can remember them as a small mnemonic as A, B, C, D, E, F, G. This is the mnemonic to remember the criteria for the damage control surgery, right? So when we say acidosis, here I mean the pH of the patient if it is less than 7.2. When I say blood pressure, it is less than 70 millimeters of mercury, that is hypotension. Presence of coagulopathy, we say decreased body temperature, that is hypothermia. If it is less than 34 degrees Celsius, serum lactate is elevated. When you say elevated, is more than 5 millimoles per liter. Fresh blood, that means it requires the blood transfusion, right? That means if the transfusion is more than 15 units, right? Again, it indicates that you need to go ahead with the protocol, right? Right. So if the injury severity score ISS is greater than 36, then these are the criteria for the damage control, right? For early total care, if the patient does not, if the patient is, in the status, we say hemodynamically stable. So when you talk about the support of inotropes, if it is not required, if the patient is normothermia, when I say air, that means patient is having no hypoxemia. Blood pressure is stable. The serum lactate is less than 2 millimoles per liter, right? So when you talk about the excretion, we're talking about the urine output. Urine output is more than 1 ml per kg per hour, and the coagulation is normal. If these are present, we can remember as the criteria for early total care. The criteria is very simple. Again, mnemonic is stable, STABLE, stable coagulation or coagulopathy is the criteria for early total care. Right. Two important topics. Do not goof up on this: criteria for damage control surgery and the criteria for early total care. Now, in trauma, another very important aspect is the shock. We talk about the hemorrhagic shock. Now, percentage of blood loss, if it is less than 15%, it is class 1, 15 to 30%, it is class 2, 30 to 40%, it is class 3, and greater than 40%, it is class 4. The heart rate remains normal here. Class 2 might be normal, it might increase. Class 3 will definitely increase. Class 4 will significantly increase. The blood pressure will remain normal in class 1 and class 2. Class 3 might remain normal or decrease, but class 4, it will definitely decrease. When we talk about the pulse pressure, it remains normal in class 1, decreases in class 2, decreases in class 3, and significantly decreases in your class 4 as well. Respiratory rate remains normal for class 1 and class 2. Class 3 also normal, may increase. Class 4, it will increase further. Urine output remains normal here. Urine output remains normal here. It becomes oliguria here, and complete abscess, that is anuria in class 4. GCS of the patient remains normal in these two status. It decreases in the class 3 and class 4. There is no need for blood transfusion here. There is may or may not require, but here it will require, and here it requires massive blood transfusion protocol. Here you will require a massive blood transfusion protocol, right? Now, when we say the massive blood transfusion protocol, I hope everybody is pretty aware of the protocol for massive blood transfusion. When we say if more than 10 units of blood is replaced within 24 hours, then we call it as the massive blood transfusion, right? Now, the preferred blood group, if it is not matched, it is O negative. Now, in order to prevent the coagulopathy, I'll be using them in 3 different components. We have the packed RBCs, we have the fresh frozen plasma, and we have the platelets, right? They all go in a ratio of 1:1:1. They all go in a ratio of 1:1:1, right? So this is about the massive blood transfusion protocol. Another important topic from the trauma is a diffuse axonal injury. Now, it is described as, majority of you know, it is a complete disruption. It's a complete disruption of axons between the white matter and the gray matter. Here, the patient is going to present to you with coma. the NC-CT of the head will remain normal, and the MRI, when you do, there is presence of punctate hemorrhage. There is presence of punctate hemorrhage between the white matter and gray matter, and it is associated with very poor prognosis. It is associated with very poor prognosis, right? So this is with respect to the diffuse axonal injury. Now, in Cushing's triad, what are the Cushing's triad? There will be presence of hypertension with bradycardia with irregular respiration. With irregular respiration. Cushing's triad basically tell you that there is raised intracranial pressure. Now remember, whenever there's a raised intracranial pressure, what will happen to the cerebral perfusion pressure? Cerebral perfusion pressure is calculated as mean arterial pressure minus intracranial pressure. Remember, the normal intracranial pressure is 5 to 15 millimeters of mercury. Remember, minimum CPP required to perfuse the brain. Minimum CPP required to perfuse the brain, it is more than 65 millimeters of mercury. So it's a range of 60 to 65. We can say it should be more than 65 millimeters of mercury, right? So these are the important aspects about the Cushing's triad. Now, when we talk about the chest injuries, we have two components of the chest injuries. One is, we call it deadly dozen, that is the immediate life-threatening, and the potentially life-threatening, right? So there are 6 of these, that is your airway obstruction, tension pneumothorax, pericardial tamponade, open pneumothorax, massive pneumothorax, tracheobronchial injury. For potential flail chest, aortic injuries, myocardial contusion, rupture of diaphragm, esophageal injuries, as well as pulmonary contusion, right? Now, remember, of all these, the most important from the exam perspective is your ruptured diaphragmatic injuries. We'll talk about in a while. Clear? Now, as I told you, diaphragmatic injuries are repeatedly asked question. What is the most common mode of injury? The answer is penetrating chest injuries, or I can say penetrating torso injuries, right? Now, which is the most common organ to herniate? It is going to be stomach, right? Large defect is associated with the blunt trauma abdomen. The bigger defect is seen in the diaphragmatic injuries if it is associated with blunt trauma to the abdomen, right? It is associated with blunt trauma to the abdomen, right? Now, which is the most common site? It is more common on the left side when compared to right, because right side it is guarded by the liver. It is guarded by liver. Now, one which is associated with poor prognosis. One associated with poor prognosis in a diaphragmatic injury, it is if it is secondary to blunt trauma. If it is secondary to blunt trauma, because the magnitude of injury is very high, right? Now, again, in order to have or suspect a diaphragmatic injury, you need to have a very high suspicion. Majority of them get missed during the initial assessment. But when you do a chest X-ray, there will be presence of nasogastric tube in thoracic cavity. As you can see here, right? You can see the nasogastric tube. In a thoracic cavity. Now, what is the best investigation? It could be direct visualization, that is your laparoscopy, or video assisted thoracoscopy, that is your VATS. Management, it is to repair the defect, or I can say bring back the content. Bring back the content and repair the defect. bring back the content and repair the defect, right? This is with respect to diaphragmatic injury. Now, what is the lethal triad of trauma? It is your metabolic acidosis, right? With hypothermia, with coagulopathy. If these three are clubbed, we call it as lethal triad of trauma. Now, how are you trying to prevent the metabolic acidosis? By giving ringer lactate. How are you trying to prevent hypothermia? By giving warm crystalloids. How are you preventing coagulopathy? By giving the packed RBCs, the fresh frozen plasma, and the platelets when required in a ratio of 1:1:1, so that you'll be able to prevent the lethal triad of trauma. You'll be able to prevent the lethal triad of trauma, right? Now, what are the stages for your damage control surgery? Now, DCS stands for the damage control surgery. Now, in damage control surgery, your stage one is your patient selection. And I've already given you the criteria for damage control surgery. Patient selection. Stage two is your primary exploration. And the goal of primary exploration, it is to control hemorrhage and prevent any further contamination. Control hemorrhage and prevent any further contamination. That is your goal of primary exploration. Stage three, it is your ICU care. The goal of the ICU care, it is to correct coagulopathy. Right. Stage four is to perform a definitive surgery. The goal of definitive surgery, it is to basically correct the anatomy. And stage five is your abdominal closure. It is the abdominal closure, right? So this is with respect to damage control surgery. Now, FAST, again, a very, very important topic from your exam perspective. They have asked you the full form itself. It stands for the focused assessment with sonography in trauma, right? Now, when you talk about the FAST, it has got a 4P evaluation. That is your perihepatic space. We have pericardiac space. We have perisplenic space and pelvic, right? So these are the 4P evaluation, right? Now you have E-fast, that means an extended fast. In an extended fast, we will look for the 6 sites. You have the 4P sites, but along with that, you will also see the right and the left thorax. Let's see, right and the left thorax. Now, minimum fluid required to say the fast is positive, it is 100 cc, right? Less than 100 cc, it cannot detect. More than 100 cc, it can. Now, one of the most important aspects for the pneumothorax in fast, if a patient develops a pneumothorax, its assessment in ultrasound, right? So normally you can see there is associated chest wall movement. It moves with the confidence. So you'll see this like it is like a seashore sign. Normally it keeps moving and comes back like a beach wave. But when the pneumothorax occurs, obviously it will not move because lungs won't be expanding and collapsing because the lungs remain in a collapsed state. So you will see the seashore sign is absent. So we say absence of seashore sign. There is absence of seashore sign, or it is also called as the barcode or the stratosphere sign. The stratosphere sign. Right? So this with respect to fast. Now, remember, fast cannot assess. Number one, if there is any retroperitoneal collection, it cannot assess bowel perforation. The fast is not very effective for retroperitoneal collection and bowel perforation. Clear? Sure. Another very important from the trauma part is your splenic trauma. Now, the most common organ injury in an abdominal trauma, obviously everybody knows it, it is going to be spleen. Blunt trauma, again, it is going to be spleen. For penetrating, it is going to be liver. For seat belt, it is going to be the mesenteric tear. For the most common abdominal organ injury in a blast injury, that is going to be the small bowel. That is going to be the small bowel, right? Now, when you talk about the grades of splenic injury, it's very simple. Hematoma occupying less than 10% of the total surface area, laceration less than 1 centimeter, right? If it is going to be 10 to 30%, or I guess 10 to 50% of the subcapsular space, laceration between 1 to 3 centimeters, greater than 50% of hematoma, greater than 3 centimeter depth of laceration. Now, grade 4, it is associated with the hilar injury, and there is intraparenchymal hemorrhage. Grade 5, it is a completely shattered spleen. It is a completely shattered spleen. For grade 1 and grade 2, it is conservative. If grade 3 patient is stable, then we'll go with conservative. If patient is unstable, then we will go with splenography. It's a spleen preserving surgery. For 4 and 5, we will go ahead with splenectomy. We'll go with emergency splenectomy. Now, because post-splenectomy, there is a risk of infection we call it as overwhelming post-splenectomy infection, that is called as OPSI. To prevent that, we have to take the patient for vaccination. Now, splenectomy vaccination in an emergency setup, right? So in an emergency, we'll see which vaccine will be given immediate post-op and which will be given within 2 weeks. So vaccine that has to be given in an immediate post-operative period and in a 2 weeks period time. Now, in an immediate post-operative, you have to give pneumococcal vaccine. Now, in pneumococcal vaccine, we will see whether the patient is less than 2 years or greater than 2 years. If it is less than 2 years, we can give a P7 vaccine. If it is more than 2 years, PPV 23 has to be done, right? P7 and a PPV 23. Now, in a 2 weeks period, I will give meningococcal and H influenza B. H influenza B, right? These are the ones which are given in post-splenectomy status. Clear? This is about the splenectomy vaccination. Now, from the head injury part, GCS is definitely important, but along with that, we have something called as the classification of head injury based upon GCS. How do you call it as minor? If the GCS is 15 with no loss of consciousness, mild GCS of 14 or 15 with loss of consciousness, moderate is GCS between 9 to 13, severe it is between 3 to 8. It is between 3 to 8. Now, what are the criteria for getting a CT within 1 hour of head injury and on a delayed basis within 8 hours of the head injury? So within 1 hour criteria, within 8 hours. Any feature that is suggestive of raised ICT, we should go ahead within 1 hour. So you have GCS less than 13 at any point, GCS less than 15 at 2 hours of observation, focal neurological deficit, suspected open or depressed fracture, more than one episode of vomiting, post-traumatic seizures. Indication, which is on within 8 hours period, there is age more than 65, coagulopathy, dangerous mechanism, and the retrograde amnesia lasting for more than 30 minutes, right? These are the criteria. Now, what are the key parameters to be maintained for a patient who has undergone a head injury and gone to a surgery, and you are putting the patient for observation, right? After the surgery. Now, we have to maintain the partial pressure of carbon dioxide between 4.5 to 5. Partial pressure of oxygen is more than 11. Mean arterial pressure should be between 80 to 90. Intracranial pressure should always be less than 20. As I told you, the minimum CPP required is 60 to 65. So the CPP, that is cerebral perfusion pressure, should be maintained more than 60. The serum sodium should be more than 140 and potassium more than 4 millimoles per liter, right? Again, very, very important from the exam perspective, right? Now we have the trauma scoring systems. We have the RTS scoring system as a revised trauma score. We have the Glasgow coma scale in that, systolic blood pressure and the respiratory rate. Based upon the values, you have given the independent scoring, and then you have to calculate the total score between 0 to 12. Okay. Now you have mangled extremity scoring system, which is called as the MES scoring system. Again, they are being given on the following characteristics, right? So the energy with which the trauma is occurred, the status of shock, the status of limb ischemia, and age of presentation. So the only components, the component of mangled extremity scoring system can be remembered as number one, the energy with which the trauma is occurred, status of limb ischemia, the status of shock, and the age of presentation. So these are the components of mangled extremity scoring system. Components of your mangled extremity scoring system. Now, when it comes to retroperitoneal hematomas, retroperitoneal hematomas. So when you look at the retroperitoneal hematomas, we have the following one. This is your zone 1. This is your zone 2. And this happens to be your zone 3. Zone 1 is also called as the central zone. This is called as the lateral zone, and this is your pelvic zone. Now remember, whenever there is presence of hematoma, if there is presence of hematoma in zone 1, it should always be explored. It should always be explored, right? Now, if there is a hematoma which is lateral, now you will see if this hematoma that is present, if this hematoma is number one, increasing in size, if it is expanding, or if it is a pulsatile hematoma, if any one is present, then this is an indication for exploration, or else you'll go with observation. The same status, the same criteria is for both pelvic as well as lateral hematomas. Therefore, same pelvic as well as lateral hematomas, right? So these are the status of your retroperitoneal hematomas. Again, important from the exam perspective. Yeah. So these are the important aspects that are to be looked across in trauma. So far, any questions, guys? Quick feedback. I can see your chat. If you have anything that you want to ask in trauma, fire it away. I'll be able to revert back to you now itself. But a ringer lactate, when you talk about in metabolic acidosis, in ringer lactate, it is not lactic acid, it is lactate. The lactate goes into liver, converts into bicarbonate. If anything, it helps treating the acidosis. All right. Yeah, guys, renal injuries are important. Again, it is grade-wise management based upon the CT. If it is limited to the capsule, conservative. If the kidney is shattered, that is when you will go and do a nephrectomy if it is beyond repair. Okay, that is the only objective. All right. Okay. So I'll take up the next topic, that is thyroid. Again, a very, very important component. Uh, we have the three things in your toxic goiters. We have the diffuse toxic, toxic multinodular, and toxic adenoma, called as primary, secondary, and autonomous adenomas, right? The status of your diffuse toxic goiter or primary thyrotoxicosis, it is seen in relatively younger patient, that is a 20 to 30 years. This is seen between 40 to 50 years, and this is seen between 30 to 50 years, right? That is any status. Now, the symptoms, they will have, all of them will have presence of the thyroid, that is hyperthyroid state. But one thing you have to remember, in primary thyrotoxicosis, the signs and symptoms of toxicosis arise first, and then you will see presence of swelling. In toxic multinodular goiter, the swelling arises first, and then there is signs and symptoms of toxicosis. Here it is together. It is your together. Here, the skin over the swelling is going to be smooth. Here, it is going to be nodular. Here, it will present to you a solitary thyroid nodule-like presentation, right? Now, the surface is in the same context. So I'll say the skin over the swelling, its surface, that is smooth nodular and STN-like presentation, right? Here, it is the CNS, which is most common involved. It is your cardiovascular system. There's nothing very severe. Here, it is usually associated with the Graves' disease. Example we're talking about, this is your plumber's disease. There is no specific example in toxic adenoma. Graves, it is autoimmune. Graves, it is autoimmune. It is associated with antibodies, that is your long-acting thyroid stimulating antibodies called as the LATs antibodies, right? Which is also called as the anti-TSH antibodies. These are your anti-TSH antibodies. It is here, it is basically the plumber's disease is because of long-standing. It is because of long-standing untreated goiter. Here it is idiopathic. Here it is idiopathic. For all of them, thyroid function test, TFT with ultrasound is to be done. So you'll do thyroid TFT here, ultrasound will be done, TFT and ultrasound will be done. There's no role of biopsy. You will also do a radioactive iodine scan with iodine 123 for all three of the following, right? For management of Graves, we will go with total, okay. We'll see age less than 40 years, age more than 40 years. Age less than 40 years, we'll go with surgery. Surgery here is total thyroidectomy. Here, if it is unilateral involvement, we will go ahead with lobectomy. If there is a bilateral involvement, we'll go with a total thyroidectomy. Here, it is only lobectomy that has to be performed. Age more than 40, I will do a radioactive iodine ablation. In a radioactive iodine ablation, we'll do with iodine 131. Here we'll still do surgery, and here we will do a radioactive iodine ablation with iodine 131. So irrespective of the age and plumber's disease, surgery should be performed. Now, when you do a radioactive iodine scan with iodine, see, when you talk about iodine 131, T half is number one, 8 days, right? The radiation that it exposes the gamma rays as well as the beta rays. It is the beta that causes ablation, or that destroys the follicular cell, right? So this is with respect to your toxic thyroid swellings. Now, when you look at the status of the radioactive iodine, if there is a diffuse active uptake, it is Graves. If it is patchy uptake, it is your toxic multinodular goiter. If there is only one, that is going to be toxic adenoma, called as the autonomous nodule as well. If there's completely destroyed thyroid gland, it is a thyroiditis. You can see if it is less uptake than surrounding, it is called as cold nodule. Remember, it is the cold nodule that is suspicious of malignancy. Cold nodule, it is suspicious of malignancy. Clear? Now, on the basis of thyroid, we have something called as the criteria for optimum cytology in your FNSC for thyroid swelling. The size of the needle should be 23 gauge. There should be 2 aspirates that have to be present. There has to be 6 follicles per aspirate, and there have to be 10 to 15 cells per follicle, right? There has to be 10 to 15 cells per follicle, right? These are the important criteria that see the optimum cytology criteria, no, that was there in your previous exam, that is your INI-CET exam as well. Now, couple of times they've asked you the size of the needle, the number of times the aspirate has to be performed, how many follicles should be there in order to call it that, it is perfect, that is 6, how many cells per follicle, that is 10 to 15 cells. Now, based upon this, you have your Thai classification, that is your FNSC based. Now, Thai one is called as the non-diagnostic aspirate. Thai 1C is your non-diagnostic cystic aspirate. Thai 2, it is your non-neoplastic. Now, as everybody knows, Thai 3 is called as follicular origin. It is referred to as the follicular origin, right? Thai 3 is your follicular origin. Now, the reason why we call it as follicular origin, because remember, FNSC cannot differentiate. It cannot differentiate between follicular adenoma and follicular carcinoma. That is why this has to be taken for lobectomy with frozen section to conclude the diagnosis, right? Thai 4, it is suspicious of malignancy. It is suspicious of malignancy. And Thai 5, it is biopsy proven malignancy. It is your biopsy proven malignancy, right? So these are the optimum cytology criteria. Clear, guys? Okay. Karthik, I didn't get your question. If you could repost it back again. All right, guys. Sure. So we talk about the inflammatory thyroid swellings. Again, a very important prospect from the exam status that we have. So I can divide them into 3 categories: Hashimoto's, decurvents, and Riedl's. Hashimoto's is an example of chronic inflammation. Decurvents is subacute. Riedl's is also an example of chronic. Hashimoto's, it is autoimmune. Decurvents, it is your post viral upper respiratory tract infection. Riedl's, it is mostly idiopathic. If not, then it is autoimmune. If not, then it is autoimmune. Now in Hashimoto's, it forms antibodies TPO antibodies. It forms an anti-TPO antibody, which will result in destruction of the follicular cells. Decurviance, it is because of cross-reacting antigens. Here it can be because of IgG4 class of antibodies, right? So that is what we say, the same, the anti-TPO antibody, there are no antibodies here, IgG4 class of antibodies. It is associated with HLA-B8, HLA-DR3, HLA-DR5. It is associated with HLA-B35. There are no specific HLAs. Hashimoto's is seen between 30 to 40 years. This is seen between 30 to 50 years. Riedl's is seen above 50 years. Or you can say 40 and above. Over 40 years. For all of them, it is the female which is more commonly affected. All of them are going to be associated female, right? There will be presence of thyroid swelling, which is noticed here. The swelling will be here. The swelling will also be here. Now, association with pain, it is not seen. The pain is here. There is no pain here, right? Now, perifibrosis with the gland. When we talk about the perifibrosis around the gland, there is here. It is again present here, right? In status of inoperability, which of the following can be inoperable? Remember, these two are inoperable and there is no need for surgery. That is not applicable in your decurvance thyroiditis, right? So there's no need for surgery across here. Now, which of the following will be associated with pressure symptoms? Pressure symptoms may or may not be here. There is no pressure symptoms here. Pressure symptoms are usually seen in Riedl's thyroiditis. Initial thyroid status here will be hyper. Here also it will be hyper. Here it is hypo since beginning. There is no intermediate. Here intermediately hypo. Here also it is hypo. Finally, it will become hypo. It will become normal. This will remain hypothyroid only, right? For all these investigations is going to be thyroid function test with ultrasound with the FNSC, right? Here, all that you need to do is your thyroid function test with ultrasound is more than enough. Here, thyroid function test with ultrasound with FNSC should be performed, right? Here it is only thyroxine. This is your self-limiting condition. And here also lifelong thyroxine should be given, right? If there are presence of severe pressure symptoms in any of the following case, then all that you have to do is to perform hysterectomy. All that you need to perform here is hysterectomy. Remember, hysterectomy is the surgery of choice to relieve pressure symptoms in an inoperable thyroid patient. In an inoperable thyroid patient, it is the treatment of choice. Clear? Okay. Sure. The syndromes are associated with thyroid cancers. Remember, FAP is associated with APC gene with papillary cancer thyroid. Gardner syndrome, again APC gene with follicular thyroid cancer. Werner syndrome with WRN gene with PTC and FTC both, along with Hurthle cell carcinoma. MEN2, it is RET gene, medullary cancer thyroid. Cowden's PTEN gene mutation with follicular as well as papillary cancer thyroid, right? Tension patient related discussion. You talk about tension pneumothorax, right? So when you talk about tension pneumothorax, the first thing that you need to know, it's a clinical diagnosis. You'll not go with any radiological investigation because it is emergency. The first thing you have to do is to decompress it. I'm going to insert the needle. Where will you insert the needle? If the patient is an adult, it is in the 5th intercostal space in the mid-axillary line. Child, 2nd intercostal space in mid-clavicular line. Both of them, I will put ICD in the 5th intercostal space. That is going to be the triangle of safety. Clear? That is the management of tension pneumothorax. See, when we talk about lobectomy, the word lobectomy now means the new hemithyroidectomy, right? The old hemithyroidectomy is now called as lobectomy. Lobectomy is lobe plus isthmus. If I use the word total lobectomy, that is lobe alone. That is lobe alone. Okay. Chalo. Now talk about the thyroid cancers. Where do they originate from? Papillary. It is going to be the follicular cells. Follicular is follicular cells. This is your follicular cells. These are your parafollicular cells. Remember, the most common is papillary. Follicular, this is the most common type in ectopic thyroid gland. In ectopic thyroid gland, anaplastic, it is associated with the worst prognosis. It is associated with the worst prognosis. See, I can see papillary at any age group, but it is usually seen between 30 to 50 years, or I can say the age group at that point. Follicular cancer is usually seen age above 50 years. Anaplastic is seen age above 60 years. Medullary, if it is associated, if it is sporadic, then it is seen after 60. If it is associated with men, it is seen in 20 to 40 years. In younger age group. For all of them, it is female, which is more commonly associated. The genes which are associated is BRAF, PTC1, PTC2, here P10 and BAX, here it is going to be red. No specific gene with your anaplastic cancer. The most important risk factor for papillary cancer, it is the radiation exposure and thyroglossal duct cyst. The most important here is going to be long standing goiter. There's going to be the long standing goiter. There's no specific risk factor here. There's no specific risk factor here as well. Clinical features here, it is going to present to you as a solitary thyroid nodule-like presentation. And it will have lateral aberrant thyroid. A lateral aberrant thyroid presentation, right? Follicular cancer thyroid, on the other hand, will present to you with goiter-like presentation. Along with goiter-like presentation, there will be presence of pulsatile forehead bony swelling. Now, the pulsatile forehead bony swelling, it is because of osteolytic secondaries. It is because of the osteolytic secondaries, right? On the other hand, the anaplastic cancer, they present you with a huge neck swelling. There will be huge neck swelling. Along with that, along with huge neck swelling, patient will also have severe pressure symptoms. Medullary cancer thyroid will have diarrhea because of excessive serotonin. Along with diarrhea, it will have solitary thyroid nodule-like presentation. The mode of spread for papillary, it is lymphatics, hematogenous, follicular, anaplastic, direct. Medullary is both lymphatics as well as blood. It is both lymphatics as well as blood. Right? Most common site for metastasis here, it is going to be lungs, it is going to be bones. Here it is going to be lungs. Here it is going to be liver. If not, then bones. When we talk about bones here, it is your osteolytic secondaries. Here it is going to be osteoblastic secondaries. Here it is going to be osteoblastic secondaries. Right? Investigations always is going to be cytology. Here, when you do FNSC, you will get a report of Thai-3 category, or also called as the Bethesda 4 category. For here, you have to take the patient for lobectomy with the frozen section. Here it is going to be FNSC. Here also it is going to be FNSC, right? Now, what are the findings that you will see across here? You can see here these empty cells. These are your orphan ANI nuclei. Orphan ANI nuclei. These are your Samoma bodies. Now, Samoma bodies are your dystrophic calcification. These are your presence of oxyphilic cells. Presence of oxyphilic cells indicates Hurthal cell carcinoma. Right. Now, these you can see, these are your amyloid in stroma that you see in medullary cancer thyroid. That you see in medullary cancer thyroid, right? So these are with respect to the salient features of the follicular cancer thyroid. Two important points. Remember, there is no role of prophylactic central neck dissection in papillary cancer thyroid and follicular cancer thyroid. There is role of prophylactic central neck dissection in medullary cancer thyroid. There is no role of radioactive iodine in medullary cancer thyroid. Right now, the medullary cancer thyroid associated with MEN syndrome, you have to screen all first degree relatives for RET mutation. You have to screen all the first degree relative with the RET mutation, right? Now, based upon this, you have the low risk for malignancy, the moderate risk for malignancy, and the high risk for malignancy. And they should undergo prophylactic total thyroidectomy. Now, for this, they should be at the age of 20 years, this at the age of 5 years, or this should be at the age of 1 year, right? So these are the age groups as which you can do a prophylactic neck dissections, or I can say total thyroidectomies, all right? So this is all the important aspects with respect to the thyroid. So far, any questions in thyroid, guys? Quick feedback. Quick feedback. All right, guys. Now let's go to the breast. Again, a very important topic from the INI-CET part of you. The first important is your BIRADS. In this BIRADS, ask what does R stands for. It is your reporting. So breast imaging, reporting, and data system. We have the categorization based upon their presentation. So category 0, incomplete assessment. What will you do? Repeat. Category 1, negative. What will you do? Routine follow-up. Category 2, benign. What will you do? Routine screening. Category 3, probably benign. Follow up after 6 months. This was your previous exam question. Category 4, you have 4A, 4B, 4C. That is your low, moderate, and high suspicious for malignancy. All of them has to be taken for biopsy. Category 5, highly suggestive of malignancy. Again, biopsy. Category 6, biopsy proven, stage-wise management. This is your BIRADS categorization, right? Now, another important topic is your breast abscess. What is the most important or the most common risk factor for breast abscess? It is lactation. Most common organism causing, it is your Staph aureus. Most common source, it is the oral cavity of the feeding baby. You can see there's a classical presence of these symptoms. So here the patient is going to have, number one, The patient is going to have severe mastalgia. Patient will have high-grade fever. Patient is going to have high-grade fever. There'll be presence of erythema, which is noticed, and there will be associated POD orange as well, right? So these are the findings that you will see here. Now, on clinical examination, you will see presence of delayed fluctuation sign. What are the sites in the body where you have collection with delayed fluctuation sign? Number one is your parotid abscess with delayed fluctuation signs. Number two, it is your pectoral abscess. Number three, it is your palmar abscess. Number four, it is your perineal abscess. And number five, it is your plantar abscess. It is your plantar abscess, right? These are the sites where you have delayed fluctuation sign. Investigation of choice, it is going to be ultrasound. The preferred management is your USG guided aspiration. USG guided aspiration with antibiotics. The second line management, if it fails, it is going to be radial incision and drainage. It is your radial incision as well as drainage. See? It is the radial incision and drainage. So, now, a very important topic in the breast is your management for breast carcinoma, especially your in situ as well as invasive malignancies. Ductal carcinoma in situ is more common when compared to lobular carcinoma in situ. Remember, lobular carcinoma in situ is actually a pre-malignant condition. The most common variety is the papillary here. The commodio, it is associated with worse prognosis or poor prognosis because it is associated with tumor necrosis. It is associated with tumor necrosis. It is associated with negative receptor status, and it is a poorly differentiated tumor, right? So these are the status that you will see across here, right? Now, a very important thing that you will see about the lobular carcinoma in situ, that around 60 to 90% of them are multicentric and 70% of them are bilateral. So there's a very high chance of having both the breast involved in this. Management here, I can either ask my patient to opt for simple mastectomy or breast conservative surgery. And if the receptor status is positive, then the hormone replacement therapy. For this, I would indicate the patient for bilateral prophylactic mastectomy. That is your risk reduction. This is under the category of risk reduction status. This is under the risk reduction status, right? Prognosis that you have, it is the Van Noa's prognostic index. The components can be remembered as VAX. W stands for the width of the tumor, which is also called as the margin of the tumor. A stands for age of presentation. G is the grade of the tumor or the histopathological type. S stands for the size of the tumor. S stands for the size of the tumor. Right, so these are with respect to the in situ malignancies and its management. Remember the pleomorphic variant of LCIS, it behaves same as ductal carcinoma in situ. So we have to treat same as DCIS. You have to treat this as same as DCIS. Clear? Okay, so now we have the TNM classification. We have discussed in detail in our regular lectures as well. So this is what you have to remember, the TNM classification. But based upon this, we divide them into the early invasive, locally advanced, and advanced breast cancer, right? How do you manage your early invasive breast cancer? A quick recap. The early invasive breast cancer, we will go with surgery. The surgery can be of two varieties, the simple mastectomy or the breast conservative surgery. The criteria for the breast conservative surgery, it should be less than 4 centimeters. There should be absence of microcalcification. It should be limited to one quadrant. It should be limited to one quadrant, and there should be absence of lymphovascular spread, right? Now, once you've done this, second is your lymph node assessment. In a lymph node assessment, we'll see clinically node positive disease and a node negative disease. Node positive, we will go ahead with axillary dissection. For a node negative disease, we have to go with sentinel lymph node biopsy and proceed. The sentinel lymph node biopsy and proceed. Okay. Now for sentinel lymph node biopsy, we can use the dye method. We can use the technetium-99 method, that is radioisotope. We can use the Centi-Mag method, that is basically using of injections of ferric oxide, right? And then you have the combined method where you're using both the dye as well as technetium. Using both the dye as well as technetium, right? Now, for locally advanced breast cancer, number one, we have to take the patient for neoadjuvant chemotherapy. After neoadjuvant chemotherapy, we'll do a modified radical mastectomy. Then in an adjuvant therapy, we'll do chemotherapy as well as post-operative radiotherapy should be given. And if the patient has ER/PR status positive, then we'll go the HRT as well. Stage 4, it is palliative. It is going to be palliative. Right? So the status of chemotherapy that you have, we have the standard CAF regime or a CMF regime. C is cyclophosphamide, adriamycin, 5-fluorouracil. Again, CMF is cyclophosphamide, methotrexate, and 5-fluorouracil. Now, in hormonal therapy, the drug of choice in premenopausal female, it is tamoxifen. The drug of choice in post-menopausal female, it is aromatase inhibitors. Now, radiotherapy can be of two varieties. Then one is your whole breast irradiation. Another one is accelerated partial breast irradiation. In an whole breast irradiation, I give the radiotherapy to the chest wall. We'll give it to the internal mammary group of lymph nodes, the supraclavicular fossa, as well as the infraclavicular fossa. The supraclavicular fossa as well as the infraclavicular fossa. Here it is only given to the tumor cavity. We are giving it to the tumor cavity and the adjacent tissue. Here it is totally for 25 days. Here we finish in 5 days, right? Here it is 1 sitting per day. Here it is 2 sitting per day. Here it is 50 to 55 gray units of radiation exposure. Here it is 30 to 35 gray units of radiation exposure. Okay. So these are the treatment options. Clear? The same thing I've mentioned across here. Okay. Luminal criteria A, we have ER/PR positive, HER2 negative. Luminal criteria B, all three are positive. It is triple positive, all three negative, triple negative, all these two negative. This is positive, HER2 When there is a HER2 positive, the first line drug that you can give is your trastuzumab. which is also called as the herceptin, right? Along with that, second line, it is your lapatinib. And then you have the sunitinib. And the sunitinib, right? So these are with respect to the luminal criteria. We have the incisions for breast surgery. The Webster and the Gilaro is for benign disorders. The Stewart and the Orr is for malignant. Simple mastectomy, we remove the stroma of the breast. We remove the glandular part of the breast along with the nipple areola is removed. In radical mastectomy, we do simple mastectomy. We remove level 1, level 2, level 3 group of lymph nodes. Along with that, we remove pectoralis major muscle as well as the pectoralis minor muscle. In modified radical mastectomy, what do you modify? We do simple mastectomy. We do remove level 1, level 2, level 3. But here I am only going to remove the pectoralis fascia, not the musculature. In Patis, there is the excision of the pectoralis minor. Scanlon, there is incision of pectoralis minor. Auchincloss, we retract the pectoralis minor. Another very important, in Auchincloss, we spare level 3 group of lymph nodes. We spare the level 3 group of lymph nodes. Yeah, guys. What are the structures to be preserved in your modified radical mastectomy? A stands for axillary vein. B stands for Bell's nerve. C stands for the cephalic vein. And D stands for nerve to the latissimus dorsi. D stands for nerve to latissimus dorsi. Complication associated modified radical mastectomy. S stands for seroma formation, which is the most common complication. W stands for winging of scapula. A stands for the arm edema, that is upper limb edema, and axillary vein thrombosis. B stands for blackening, and blackening indicates flap necrosis. It indicates flap necrosis, right? So these are the components with respect to the breast, right? So far, any questions, guys? Quick feedback. Okay. So you talk about the hernia, especially you're talking about the inguinal hernia repairs. Now, when it comes to the open repair, the surgery of choice, it is your Lichtenstein tension-free mesh repair. It is your Lichtenstein tension-free mesh repair. Now, the most common mesh material which is used, it is your Prolene mesh. Now, what is an ideal characteristic? When you talk about ideal characteristic, it should be like, I'm talking about ideal characteristic of the mesh. It should be light weight, less than 40 grams per meter square, right? It should be lightweight. It should have a large pore, and it should be hydrophobic. It should be hydrophobic. Now, how should be the overlap? When you talk about the mesh overlap, let's say this is the defect that is present, and we have decided to cover up the defect with a mesh, and we have put the mesh across here. Remember, the minimum overlap is going to be 2 centimeters. The ideal overlap is going to be 5 centimeters. Right, so this is the minimum overlap. This happens to be the ideal overlap, right? Now, what is the most common nerve damage in open hernia repair? It is the ilio-inguinal nerve, right? Which is the most common nerve damage in laparoscopic hernia repair, that is inguinal hernia repair. It is your lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh, right? Now, if they ask you what is the most common nerve trapped in mesh, that is your ilio-hypogastric nerve. It is the ilio-hypogastric nerve, right? The most common cause for chronic inguinalodynia, that is chronic inguinal pain after the hernia repair, it is because of ilio-hypogastric nerve trapped in mesh. It is trapped in mesh, right? If there is damage to the ilio-inguinal nerve, there will be loss of sensation to that area as well as the root of the penis in males. Okay? So these are the important aspects with respect to the inguinal hernia repairs. Clear? Sure. So far, any questions, guys? Quick feedback. Now, infections in liver, pyogenic liver abscess, the most common causative agent is going to be E. coli or Klebsiella. Amoebic is your Entamoeba histolytica. Hydrated cyst is your Echinococcus granulosus. Now, route of spread for pyogenic liver abscess is via the bile duct. These two is via the portal circulation. Pyogenic liver abscess is seen in age above 50 years, right? So when you talk about the pyogenic liver abscess, it is more or less, right? It is seen in the patients who are having the chronic alcoholic status, they are diabetic. So in those patients, the age is above usually more than 50, right? The age is more than 50. Clear? A few questions. Guys, you can also post the questions on the Zoom, right? If you've joined the link via the Zoom, you can also post your questions there also. Clear? Yeah. Okay. Fine. Amoebic liver abscess, you will be seeing in age between 20 to 40 years. That is the usual age of presentation. Hydrated cyst is between 40 to 50 years, right? Pyogenic liver abscess is more commonly seen in males. Amoebic liver abscess is more commonly seen in males. Hydrated cyst is equally seen in males as well as females. For all of them, it is the right side of the liver which is more common. These are usually multiple. This is usually solitary. This is usually solitary. Hydrated cyst is also usually solitary. These two, I mean, this is not endemic. This may be endemic. Hydrated cyst is endemic. First investigation is going to be ultrasound for hydrated cyst. We have a classification as was Garbi classification. Type 1, it is called as a simple cyst. Type 2, it is called as the water lily type, or also called as the water snake type, right? Type 3, it is called as the honeycomb, or I can say multiseptate. Also called as the honeycomb variety. Type 4, it is your complex heterogeneous. It is your complex heterogeneous. Type 5, it is a calcified cyst. It is a calcified cyst. Right? Sure. So these are the investigations to confirm. We have given all of them. ELISA is the best one for the parasites. For management, it is going to be USG guided drainage with antibiotics. Here it is going to be high dose metronidazole. It is your high dose metronidazole. Here we do something called as pair therapy. That is your percutaneous aspiration of hydrated fluid with instillation of scolicidal agent, installation of scolicidal agent, and re-aspiration. Right? This is what how you manage your infective disorders in liver. All right, guys. Sure. So when you talk about the benign tumors of the liver, three important ones. Hemangioma is the most common benign liver lesion. It is a vascular malformation. Focal nodal hyperplasia, it is hyperplasia. It is hyperplasia in response to vascular malformation. In response to vascular malformation, right? Hepatic adenoma, it is basically a true benign tumor. It's a true benign tumor. 20% of them are your hemangioma, only 1% is your focal nodal hyperplasia, 0.5% is your hepatic adenoma. Hemangioma, there are no specific risk factors. For here, it is associated with OCP. It is associated with glycogen storage disease. It is associated with glycogen storage disease. That is a type 1 and type 3. It is also associated with non-alcoholic fatty liver disease. It is also associated non-alcoholic fatty liver disease. These two are not pre-malignant. This is pre-malignant. Remember HNF alpha, I mean, there's an increased mutation of gene that is called as HNF alpha mutation that is associated with hepatic adenoma, right? They're not having any specific features. There's no specific complication except for hemorrhage here. Here also it is hypervascular, so it can result in hemorrhage, or it can be associated with the malignant transformation. it is associated malignant transformation, right? Now, investigation of choice is going to be the triple phase CT for all three of them. Management observation. Here also observation. Here less than 5 centimeters observation. More than 5 centimeters, you can go with excision. Right? Focal nodular hyperplasia on CT, you will get a central stellate scar. There will be presence of a central stellate scar. Right? So these are with respect to your hepatic benign disorders, right? So far, any questions, guys? Quick feedback. Quick feedback. All right, sure. So again, very important topic from the INI perspective is your drains. Just simply remember there, these are your corrugated rubber drain. This is a pen rose drain. This is corrugated latex drain. This is your corrugated silicon drain, right? This is your Romo-Vac drain. It's a negative suction drain. This is your Foley's catheter. This happens to be a T-tube. This is a 3-ways Foley's catheter. This is used for bladder irrigation. This is your pigtail. This happens to be your pigtail, right? This is your nasogastric tube, also called as the Riles tube. This is your Syngaskin Blakemore tube, SBT tube, which is used for a balloon tamponade. It is used for the balloon tamponade in bleeding esophageal varices. In bleeding esophageal varices, right? There are two balloons. This is your gastric balloon. This is your esophageal balloon, right? So gastric balloon is inflated with 300 ml of air. This is inflated with 40 millimeters of mercury pressure. Inflated with 40 millimeters of mercury pressure. This is your Jackson rat drain. This happens to be your Jackson rat drain. All right. Now again, your canvas, color code, size, and flow, all these are important. Quick feedback again here. Orange is going to be your 14 gauge. This is your 16 gauge. This is your 18 gauge. This is your 20 gauge. This is your 22 gauge. This is your 24 gauge. And this is your 26 gauge, right? So orange, gray, green, pink, blue, yellow, as well as violet or purple. This has a 240. We're talking about ml per minute. This has got 180 ml per minute. This is 90. This is 65. This is 30. This is 20. And this is going to be 12 ml per minute, right? So these are the cannula size as well as their flow rates, right? Laparoscopy, important aspects. This is what we call it as the port. This is a trocar. This is a bigger one, a 10 millimeter port. The smaller one is called as a 5 millimeter port. This is the lens used. It is at a 30-degree angle. You see there is a blunt trocar. Presence of a blunt trocar is called as the Hansen's port. This is your Veress needle. This happens to be your Veress needle. Now, Veress needle is used to create pneumoperitoneum. This is called as SILS. SILS stands for single incision laparoscopic port surgery. This is your single incision. This is your single incision laparoscopic port surgery, that is SILS, right? Now, a couple of important questions. angle between the varus needle and the body during the entry. When you're inserting the varus needle into the body, the angle is going to be 90 degrees, right? Varus needle is pointed towards the pelvis when you are inserting the varus needle. The most common gas used to create pneumoperitoneum is carbon dioxide. What is the initial flow rate of carbon dioxide? Is 1 to 4 liters per minute. What is the maximum flow rate? It is 20 liters per minute. How much should be the pressure? It should be less than 15 millimeters of mercury. If there is an accidental injury during the port placement, accidental port placement injury, keep the port in situ and perform laparotomy. Right? So these are with respect to the laparoscopic instrumental status, right? Now, these are the angles that you need to know with respect to laparoscope. The angle number 3, which is present here, this is called as the elevating angle. The elevating angle is the angle between the instrument and the optical orientation, right? This, the angle number 2 between the instrument and the optical. This is the working port number 1. This is the working port number 2. This is the optical port. The angle between the working port and the optical port, it is called as the azimuth angle. This is called as the azimuth angle. And between the two working ports, this is called as the manipulating angle. This is the manipulating angle. These are the angles that they can ask you, right? Now, energy devices, monopolar, bipolar, harmonic, thunderbeat. They will basically, when we say monopolars, they have a single pole. Bipolar, you have 2 poles. Out of these 2, which will require an earthing plate, monopolar requires an earthing plate, whereas bipolar does not require. Now, when it comes down to the energy devices, no, for monopolar and bipolar, we have something called as the cut mode, the coagulate mode, and then you have something called as the blend mode, right? Now, what do you mean by this? So basically, for a cut, no, you require low voltage current and a high frequency flow, right? Coagulate requires high voltage of flow, but requires low frequency of current. High voltage, but low frequency. It requires moderate voltage and moderate frequency to create the blend mode, right? So for cut, coagulate, and blend. Here for harmonic scalpel, remember the frequency at which it has to vibrate is your 20,000 hertz to 50,000 hertz. This is the vibrating mode. It basically helps by protein denaturation. Due to vibrating energy. Now, this energy source is safe in patients with pacemaker. It is with pacemaker. This is called as a combined energy source. Thunderbeat is a combined energy source which uses both the electrical as well as ultrasound, right? So it is going to use both the electrical energy as well as the ultrasonic energy, right? It's a combined energy device. Clear? Now, the standard suturing rule that they can ask you, how do you measure the length of the suture material? It should be 4 times the length of the wound. What is the depth of the wound? Let's say the depth of the wound here taken as X centimeter. The angle between the needle and the skin is going to be 90 degrees. The distance between the two sutures will be twice the depth of the wound, and the length of the suture here is going to be 1 to 2 millimeters, right? So distance from the edge should be same as the depth of the wound. Distance between the two sutures should be twice the depth of the wound. This is your standard suturing rule, right? Now, this is called as a simple continuous sutures. This is called as a simple interrupted sutures. This is called as the vertical mattress sutures. These are called as the horizontal, excuse me guys, the horizontal mattress sutures, and this is your subcuticular sutures. These are your subcuticular sutures, right? The knotting technique, this is called as a half hitch. This is called as the half hitch. This is what we call it as the granny's knot. This is called as the granny's knot. Remember, granny's knot is unstable. Now, how do you identify the granny's knot? In order to identify the granny's knot, you can see one thread is going under the loop, one is going over the loop. Here, one thread under, one thread over. So one going above, one going below, it is your granny's knot. This is what we call it as the square knot, also referred to as the reef knot. And this indicates a stable knot. This indicates a stable knot, right? On the other hand, when you look across here, this is what we call it as the surgeon's knot. This is what we call it as the surgeon's knot. This is the surgeon's knot, and this is a stable knot, right? Now, suture removal period. This is again important. On the face, we'll remove between 3 to 5 days. Scalp is 7 to 10 days. Arms is also going to be 7 to 10 days. Trunk is 10 to 14 days. Legs is going to be 10 to 14 days. The hand and feet is also 10 to 14 days. Palms and soles is going to be 14 to 21 days. It is going to be 14 to 21 days, right? So these are with respect to your suture removal status, right? So these are the quick revision of the important topics for your INI-CET. I've given you a list that you need to watch out for, and this is in your core concepts that I could summarize, right? So I'll be here for you guys to take some doubts. If you have any, please share it across. So this is from a rapid fire that I wanted to give you before the exam, just to boost your confidence. These are a must-know topics, a repeat status topics. All right, guys. So if any questions, please fire it away. Otherwise, that's it from my end, guys. Thank you. All the best for the exam. Do well. Keep yourself calm. Just let it absorb, soak it in, and give your best. Yes, I will be sending the PDF, guys. Don't worry about it. Right? Sure. Thank you, guys. Thank you. Have a good time. Thank you. PDF. Yes, guys, I'll send you the PDF. Don't worry. Thank you. Signing off.